Hi, everyone. My name is Laura Olafson, and I'm doing my abdominal focus exam on cholecystitis. Important subjective information to gather from our patients prior to the physical exam would include HPI information, age, gender, race, BMI, hormones, cholesterol. All of those factors can contribute to a higher risk for cholecystitis. Past medical, family, social history would be important to gather. And then the pain specifically, we're going to do old carts, obviously trying to gather as much information as possible about the characteristics, location, duration, relieving factors, all that of the pain. Medications would be important to go over, certainly dosages. An increased dose in NSAID could potentially cause liver inflammation, for example. Abdominal or weight loss surgery would be a pertinent thing to discuss, specifically weight loss within a short period of time, whether it be related to surgery or not, could put a patient at higher risk of cholecystitis. And then diet and alcohol intake would be important to go over as well. As discussed, for review of systems, we would be talking about pain and then any signs of systemic inflammation, such as fever, fatigue, weakness, nausea, vomiting, and then we'd want to discuss bowel and bladder habits and characteristics as well. Normal findings for an abdominal focused exam include it being negative for pain upon palpation or not. In general, pain would be an abnormal finding. The skin should be a normal temperature and appearance, so non-erythemic and non-jaundiced. The abdomen itself should be symmetrical and not only in general, soft, round, non-tender, but also symmetrical with movement such as breathing. Normal active bowel sounds should be heard in all four quadrants. Arteries, all of the abdominal and inguinal arteries should be negative for bruit, rubs or hums. And then palpation, normally your liver is palpated 2 to 3 centimeters below the costal region. And if it's below that, it could be possibly considered enlarged. In the liver in itself should be 6 to 12 centimeters long. The spleen on the other side of the body, on the left side, should not be palpable in most people. And then the gallbladder and kidneys should not be tender upon palpation. Moving on to the focused exam here. For a patient coming in with likely cholecystitis, I would address the patient and go over all the questions that we just discussed in my PowerPoint. And then starting in on the physical exam, I'm going to lift up your shirt if that's okay. And then I'm going to visually inspect the abdomen, both from the side and from the foot of the bed, looking for symmetry, both just in general, if the abdomen is round, flat, or distended, and then also symmetry with breathing. I'm looking at the skin tone for jaundice or erythemia. I will auscultate next, and doing so, I'm going to feel the temperature of the skin as I go as well, making sure the temperature is in normal limits. So starting in that right lower quadrant, I'm listening in all four quadrants for bowel sounds. Normal active bowel sounds are 5 to 30 per minute. Next, I'm going to auscultate the abdominal aorta with both sides of the stethoscope, and then any bruits or rubs or hums would be abnormal. I might also, if this were an actual exam, listen to the inguinal and renal arteries as well. Moving on to percussion, I'm going to start at 2 to 3 centimeters below the costal border, mid-clavicular on this right side. feeling for liver or hearing for liver. And finding that border, I might do a scratch test to mark it, moving upward along that midclavicular line, usually between the fourth and fifth intercostal spaces where you'll find the top border of that. Typical liver is 12 to 6 centimeters in length. So the spleen on the other side here is percussed by first going over that last intercostal space and having the patient take a deep breath. And noting if there's a change in the tympany from tympanic to dull, which would indicate an enlarged spleen. Moving on to light palpation, feeling for any overt masses or tenderness. I could do a rebound tenderness check at this point as well. I don't feel anything. The next would be moving to that lower boundary of the liver and palpating hard against it where the gallbladder is found and having the patient take a deep breath. Good. If there were a sudden cessation in breathing or marked pain, that would be a positive Murphy sign. Deep palpation of the liver is a scoop underneath that costal region and feeling the borders. Again, marking any tenderness or enlargement. Typically, the spleen is not palpable on most people, but it would be on the opposing side here. Again, underneath that costal space. And then lastly, I'm going to palpate the kidneys, which places one hand underneath the patient and then the other on top, and pulling my hands together, trying to scoop that kidney into a position where I can feel it. And that pretty much sums up the focused abdominal. Okay. So then abnormal findings for that exam would include the right upper quadrant pain. Sometimes with cholecystitis, referred pain can be felt at the right subscapular region. Of course, nausea, vomiting, increased flatulence, increased pain after eating in that right upper quadrant area. Steatorrhea can be seen, jaundice if the obstruction is bad enough, and systemic inflammation. Lab-wise, abnormal findings would be an elevated white blood cell count or CRP. I've also read a study that indicated that elevated immature granulocyte and neutrophil counts can be an early indicator of cholecystitis. Positive Murphy sign as discussed in the exam, and then an ultrasound would show wall thickening in the gallbladder, edema, enlargement, distension of the gallbladder, potentially gallbladder stones, and then pericholecystic fluid collection. And then, of course, in most severe cases, could result in sepsis or even death. Differentials include appendicitis, irritable bowel syndrome, and peptic ulcer disease. And here are my references. Thank you very much.